Welcome to the Iron Direct Primary Care Podcast. I'm your host, Stefan, joined here with my wife, Logan, today on a recap of 2025 A4M Las Vegas. The American Academy of Anti-Aging Medicine is the biggest conference on the planet for anti-aging medicine. This one broke all records, I think close to 8,000 attendees.
It was huge.
It was huge. And that just goes to show that we are at the leading edge, and everybody else wants to be here with us because a lot has happened in 2025. The FDA chief, Dr. Makary, says that the greatest neglect to females that medicine has done is withhold hormone therapy from women, and that shook the system to its core. Right, the Women's Health Initiative, taking a look at that again, the data showing that we need to be treating women with hormones as part of routine primary care. That was huge. 2025 was also pretty huge for peptides. That's really when peptides hit the mainstream. And I feel that peptides, especially GLP-1 medications, it's essentially functional medicine for the mainstream medicine, because GLP-1 peptides, they don't just treat for weight. They're not only a pancreatic drug. It works for inflammation. It works for joint pain. It works for migraines, cognition,
mental health.
So it's the first introduction to mainstream medicine of functional medicine, where one drug doesn't just treat one organ system. It's a multi-system approach. So that's pretty revolutionary, and that's part of why I think GLP-1s have taken the world by storm. It's because it's the first step towards functional medicine. It's easy to administer. It's an injection, and then you're treating not just diabetes. You're treating multi-systems at once, and that's functional medicine. Pretty cool.
It's pretty cool.
So we're going to go through today what we learned at A4M, some of the highlights, the takeaway points. Thankfully, Logan has a photographic memory because I don't.
I have the slides in my head and I just take pictures.
Yeah, I actually have to take physical pictures, which I do have some, which we'll put up on the screen. But Logan has photographic memory.
I think I get that from my mom, but yeah, it's kind of funny.
So the conference is started out with Sarah Gottfried speaking, Dr. Sarah Gottfried.
Yeah, hers, I think that was the first lecture that we listened to. And it was a good start to the conference. She had a lot to say, in particular, something that stuck out to me. Well, two things, but the first was that the highest concentration of mitochondria is actually in the ovaries. So what that tells me is two things. One, as you age, your ovaries eventually, they shut down, right? And that's why your FSH skyrockets, because it's basically screaming at your ovaries, make more estradiol, but they don't because they shut down. And so the highest density is in the ovaries. So as you age, imagine how much mitochondria you're losing.
Right.
A ton. And so not only are women having issues because they're losing estradiol because the ovaries basically go to sleep indefinitely, but you're losing mitochondria. So then you're getting like a 2-for-1 hit, right? And so women, then they get major brain fog. They get mood changes. They don't have the energy to work out anymore. They get super fatigued. Everything starts basically kind of going downhill a bit. I mean, not to sound doomer, but that's just a reality. And then the other thing is in premenopausal women, if their ovaries aren't functioning well, which is a lot of women have hormonal imbalance, they're going to have a lot of those same issues, even though their ovaries are still there, still should be working. But if they have an imbalance, if they have too much testosterone or not enough estradiol, you're going to have basically low quality ovaries, low quality eggs. So that's going to affect a lot of things. And so that was huge. I didn't know that.
To put it into perspective, I have a slide here. Oocytes, the ovaries, contain 100,000 to 1 million mitochondria per cell. The heart muscle contains about 5,000. Skeletal muscle contains between 200 to 2,500. And the neurons, liver, and kidney contain about 1,000 to 2,000 mitochondria per cell. So the oocytes, the ovaries, are this massive mitochondrial storage house.
It's amazing. Who would have thought? I mean, that's crazy. Like the ovaries are super dense in mitochondria.
some of the other things that she put up there is ovarian health beyond reproduction. Ovarian health regulates female systemic aging. Young ovary transplantation in old mice extends lifespan by 6 to 11%. And the effect size tied to donor ovary age.
Well, yeah. And one thing she also mentioned was, and this might trigger some people, but it's the reality of what it is. It's just, this is what happens is menopause is a time of rapid aging. It just is, because if you lose and you don't replace estradiol, it's a time of rapid aging, right?
Yeah.
And so, you just threw me off there.
Go ahead.
It's a time of rapid aging, right? So unfortunately, if women aren't replacing that estradiol, they're going to experience those side effects of having the low estradiol, which is your hippocampus in your brain shrinks. And that's kind of a scary thing, right? And she even mentioned that after 7 years, if you don't replace the estradiol, that could potentially be permanent. Not always, but could be. And then factor in all the other issues that you can have as well with cognition and then cardiovascular disease. It's a time of rapid aging for women.
The key point is to start HRT early.
Yep.
It doesn't mean that if you've missed the boat, as most women have, they've been neglected for the past 7 years. Maybe they're age 60, 70 right now. You can still start HRT. It's not too late.
Yeah, they still should.
But ideally, you don't wait for the symptoms to set in, right? The osteopenia, the frailty, the cognitive decline, the cardiovascular disease. You want to start optimizing hormones very early on, testing hormones early on in your life when you're still healthy, young oocytes, right? Age 20s, 30s, know what a baseline of good hormones might look like. But then really before menopause sets in, you're looking at progesterone and you're optimizing that. You're optimizing estradiol early.
Yeah, and that's the thing you mentioned as well. Even in perimenopause, like if your estradiol is low in perimenopause, which normally it is, you might have fluctuations because, again, you're having this issue with FSH and the ovaries. There's a disconnection there. But you should start replacing the estradiol even in perimenopause. Don't wait until they're fully menopausal to give them estradiol because they're missing out on those benefits. You should start it as early as needed. And some women start experiencing perimenopausal symptoms in their late 30s. So if they're having low estradiol, you can start replacing that early. Don't wait until they're suffering at 55, you know?
All right, let's take a look at what else she posted here. If you look at brain scans of men and women in midlife, say their 40s through their 60s, the women show more plaque, more brain atrophy, reduced connectivity, and reduced glucose metabolism. We should not think of dementia as a disease that starts in old age.
Yeah, it's going to start. I mean, that can start early. And the thing with dementia, obviously, is it's multifactorial. It's not just because there's no hormones. It's not just because there's hyperglycemia. It's not just because it's dyslipidemia. It's all these things. But the problem is once you start losing the hormones and you start aging, all those other risk factors increase, right? So you're going to be more prone to hyperglycemia, dyslipidemia. Your ApoB is going to increase with age. All these factors that we know increase your risk for dementia. So it's kind of this multifactorial thing. The other thing, speaking of hormones, and in particular estradiol, my favorite hormone, they talked about dosing estradiol based on FSH, which I think is brilliant because I think with estradiol, it can be confusing because women have a lot of potential side effects to it, right? So you can have different side effects. Sometimes women will get breast tenderness. Sometimes they might get some breakthrough bleeding, et cetera, et cetera. So there's not really this gold standard number to follow. Like they need to be this number because every woman's a little different. But if you're dosing it to a range with FSH, and in particular, I think it was Sarah who said around 5 to 25. That's where you should try to dose the FSH. And that's a pretty big range still. Then you can at least get enough estradiol to where you're suppressing the FSH because when they don't have enough estradiol, that FSH is going to be through the roof. So at least you have some way to kind of gauge what's an appropriate dose for most people. Again, everybody's different, so it's not going to be the same for everybody, but you at least have something to work with there. Can I at least suppress it below 25? And that's going to give them a really good cardioprotective, neuroprotective, bone protective level.
Right. The optimal was between 5 and 20, 25.
Correct.
So anywhere between there. But I just don't think many women are at that level.
No, they're not. And you know what? That's still a pretty good range, because technically if you're premenopausal, you don't want an FSH above, say, 10 to 12, because that means actually you may have an issue with like premature ovarian insufficiency. So you're still giving quite a bit of wiggle room. I mean, you're not suppressing it so much that you're making them a premenopausal level, because 25 is way too high for a woman that's still having cycles. That would mean that there's something wrong. So that's still a pretty good leeway and something that we can aim for with hormone replacement.
100%. So that's the new 2026 Iron DPC protocols to get women optimized with an FSH under 25 with HRT.
Well, and that's the difference, right? Because you can treat symptoms. It's easy to treat symptoms. It's easy to treat a hot flash. It's easy to maybe treat the libido. But if you want, we're talking about optimization, longevity, and health span, that's where you start tinkering with trying to get that FSH below 25, or trying to maybe cycle the estradiol and the progesterone versus taking it every single day. That's the difference between suppressing symptoms and then actually optimizing for the most benefits.
Right. With aging, there can be a decline in the brain's ability to generate the fuel it needs. The key is maintaining the body's system of glucose metabolism, and that entire process in women is regulated by estrogen. That's from Roberta Brinton, PhD.
Well, and I think that's also why women might live their whole lives until menopause one way, and then all of a sudden when menopause or perimenopause really hits, they start noticing the weight gain. They start noticing the brain fog. They start noticing I'm more fatigued. All these things that they didn't have before, and they haven't changed anything, and now all of a sudden they're having these issues, right? Because, as you mentioned, since estradiol is controlling a lot of that glucose metabolism, they're not going to be able to eat the way they did when they're 25. It's just true. I mean, you can't continue the same way. You have to change the way you eat, change the way you train. There's a lot of things you have to do different. Now, again, if you optimize your estradiol, maybe there's a little bit more wiggle room, but that doesn't mean that you can just take enough estradiol and eat the way you did when you were 20. That's not the case either. But it just goes to show you that's why people suddenly have these changes after menopause that they didn't have their whole life.
I mean, who knew that the mitochondria declined so rapidly with menopause? Mitochondria, I mean, that is the powerhouse of the cell. This is energy.
Yeah.
It's its purest form. If you have a rapid decline of your mitochondria, yeah, I guess metabolism does change with age for women.
And just the level of energy. The level of energy changes. I mean, we can see it. We can see it in people that we know personally, aunts, mothers, grandmothers. Things change after menopause. They don't have the same level of energy. They don't have the same level of pep in their step. Things change because they lose so much of that energy source that they once had.
That's insane. I mean,
it is.
I try to encourage all patients to build muscle because I've thought, and it's correct though, that muscle regulates your metabolism, but ovaries way more powerful than muscle as far as mitochondria are concerned.
So just think about, though, how important it is then to have good ovarian health throughout your whole life. And a lot of women don't, because, again, a lot of women have a hormonal disturbance. I can't tell you how many charts that we have where women have, a relative estrogen dominance. I hate that word because they're not really estrogen dominant. It's just in comparison to their progesterone, maybe their estrogen is a little bit higher. But that doesn't mean lower the estradiol. That means increase the progesterone. But same thing with the testosterone. They'll be a little bit more androgen dominant, right? And so that actually is bad for the ovaries. To be androgen dominant, it destroys the ovaries. So just think of how important it is to have good ovarian health as well when you're premenopausal.
Perimenopause is the most symptomatic time in the female life cycle. 100 plus symptoms and aging acceleration, loss of mitochondrial function, and metabolic health. Huge.
Well, one of the reasons that is why women have the most symptoms during perimenopause is because the ovaries haven't quite gone to sleep. So they're still functioning enough to where those occasional pulses of FSH from the pituitary will occasionally cause a bit of an estrogen spike, right? And so the ovaries are kind of starting to go to sleep, but the FSH is kind of hitting them over and over, like wake up, make estradiol. And occasionally they will make a little bit. So they'll get this little rapid fire, but then it'll kind of go quiet again for a little bit. And so that's really difficult to have these high peaks of estradiol where you start feeling a bit better and then you have a very big dip again. And so that's why they're so symptomatic, because they're occasionally getting little bumps, if you will, of hormones, but then it goes away. Whereas in menopause, it's gone completely. So everything is kind of at baseline. So I can see why in perimenopause, it would be the worst time. And especially think if you're not treating, you could treat them with estradiol in perimenopause and kind of solve that problem. But everybody's so scared of estrogen. And they're scared of giving it before menopause, which I think is silly. But you can actually treat that quite easily.
Yep. Is a time of decreased cerebral metabolism as measured with PET related to estrogen decline and mitochondrial impairment. So address this with early testing lifestyle medicine to include practical lifestyle levers, supplementation, and bioidentical hormone therapy.
Mm-hmm. Well, and if I remember correct too, Dr. Gottenfried even starts doing calcium score testing after 40, if it's indicated. And she also does many mental status exams, even in her young patients, because you start seeing those changes early as estrogen declines. And so she's really trying to track all of these changes before patients end up with dementia or before they end up with an MI, which I think is really cool. I mean, that's preventative medicine.
I mean, truly. I mean, MI, cognitive decline, Alzheimer's are going to be the leading causes of death. I mean, it's like Alzheimer's, cardiovascular disease, I think cancer. It's like the top three. Right? And you can prevent Alzheimer's and cardiovascular disease with early HRT for women. It's quite clear. So, and we know now that estrogen doesn't necessarily cause breast cancer.
No.
It's all about balance. And there's some women that we know do have breast cancers, and then the conventional approach is like blocking estrogen in the body. And so I think that gets the idea that estrogen causes cancer. It's a treatment in worst case scenario in oncology. That's the standard of care, right? It's estrogen blockade. But I think that filters down into the general population, and then they make the connection that estrogen causes cancer.
Well, and I think the problem is cancer at its, I don't want to say at its root because there's a lot of factors, but cancer is really an issue with the immune system.
Right.
Because your immune system should be healthy enough to clear out senescent cells or malignant or dysplastic cells. That's the whole point. So cancer isn't a estrogen issue. Now, one could argue if you have a poor immune system for whatever reason, and there's many reasons for that, but if you have a poor immune system, you're not clearing out senescent cells, then sure, maybe too much estradiol could encourage growth, but it's not the estradiol. That's not the issue. The issue is something that precedes that. So that's, I think, but that's hard for people to understand because they just hear block estrogen caused it. It didn't cause the cancer.
Right.
The cancer was your body could not clear those senescent cells for some reason. And that's multifactorial, but that's
a whole nother podcast
yeah, it's way
topic.
past this.
And then the next lecture we listened to is Gabrielle Lyons, and she gave the muscle-centric medicine approach. I love that lecture. I've given that lecture on my own many times, even before I knew she existed. So really cool slide here is the loss of lean body mass and associated complications. So when you have 10% loss of lean body mass, you have decreased immunity and increased risk of infection. 20% loss of lean body mass, you have decreased wound healing, increased muscle weakness, increased risk of infection. 30% loss of lean body mass, you'll have difficulty sitting, pressure ulcers, pneumonia, inability to heal. And then when you have 40% loss of lean body mass, you have increased risk of death, usually from pneumonia.
It's terrible. It's terrible statistics. It's really bad to have low muscle mass.
Terrible.
It's terrible. And the worst part is as you age, it's the risks are much worse. So the older you get and the more muscle you lose, or rather the more muscle that you don't put on, is worse for your age.
Right.
It's terrible. It's dangerous. And it's hard because people don't want to do the hard things. They don't want to go to the gym. They don't want to do progressive overload. They don't want to do the hard things, but the hard things are actually the life-saving things.
Right.
You know?
And then in medicine, what we do, and we need to get better about saying this, is anabolic steroid therapy. And this can be something as simple as DHEA and pregnenolone.
Sure.
Or it can be testosterone replacement therapy for men and women, but women in particular. Everyone gets scared that everyone doesn't want to say, oh, anabolic steroid therapy, that's for bodybuilders. No, that's for everybody. You produce anabolic steroids every day. If you're anabolic steroid deficient, you're going to have muscle wasting and rapid decline of age. Then you compound that with not hitting the gym because you'd like to, walk your dog for exercise.
Walking's not enough.
Walking isn't enough. Sorry.
Walking is good if you're going to do 30, 60 minutes of walking and hit and lifting.
Right.
Then it's great. But you can't just, you're right. You can't just go for a walk with your dog and it'd be enough. It's not. You need cardio and you need the resistance training, but especially as you age, the resistance training is incredibly important. And you mentioned the anabolic steroids. Well, guess what increases as you age? A catabolic hormone called cortisol.
Right.
So then again, you're battling, you have low muscle mass, and then you're producing more cortisol, which is catabolic.
Or it's really not about, sometimes people don't produce cortisol.
Yeah, that's another,
But it can be just an imbalance, right? They lack the androgens. They're still producing cortisol. Like, what are the hormones that women still produce with age? Cortisol. But they don't produce estrogen. They don't produce progesterone. They may not produce much testosterone. They don't probably produce much DHA or pregnenolone. So the only hormone they're probably still producing with age is cortisol, the catabolic hormone of the body.
Correct.
So the balance is lost.
And for about a third of women, they will go on to still produce testosterone and DHEA, which some could argue can be worse because if they're androgen dominant and don't have any estradiol or progesterone, they're actually going to become a little bit insulin resistant because they're getting too much androgens and cortisol. So that's also a bad scenario on either way. Either flip of the coin is not really good. So ideally, you want everything to be in harmony. You want enough androgens, you want enough estradiol, enough progesterone, DHEA, pregnenolone, cortisol. You want that all in harmony because if they're not, you're going to have an imbalance.
Yep. So what did Dr. Lyon say? Increased muscle span leads to greater strength reserve, greater health and well-being, and greater function and independence with age. You need to invest in your health now so that you don't have to invest in a $20,000 a month nursing or assisted living facility.
Yeah.
People want to be about cheap now because they're age 60. I got to save money. I'm not going to invest in hormone therapy. I'm not going to invest in a trainer. Well, guess what? Medicare doesn't pick up the tab for your nursing home until you've exhausted all your savings.
Terrible.
So there goes your inheritance for your children. There goes your house. There goes everything you saved up throughout the years. Nursing homes are crazy. Look at some of the ones up in Indian Harbor Beach, $10,000, $20,000 a month. Boom, that savings goes by in a flash.
Yeah, that's crazy.
Right? So point of the story is invest now in your health.
Yeah, I was thinking about that actually when we were at my grandparents on Christmas Eve, and I was watching my grandmother carry all those like huge, heavy gifts out for the gift exchange. And I was like, this is kind of what people can hope to achieve is at least, when you're in your mid 80s, that you have no issues with, bending down or moving or lifting heavy things. I mean, I'd like to do even more at that age. I mean, I'd like to still be, lifting, et cetera, but that's kind of what we should aim for in your 80s. You're still very involved. You have no issue lifting anything heavy. You don't have any limitations. You can sit anywhere. You can do anything. You're still driving. You don't want to be one of those 80-year-olds that's paying $10K a month to live in a home.
No.
where you have no control over anything either.
Right.
That sucks.
It's
and
terrible.
you can ameliorate that or at least decrease that risk by having muscle mass. I mean, it's easier said than done because, again, nobody wants to do the hard work, but...
Clinical evidence that your muscles are unhealthy. So you can check this right now, viewers.
Oh, I remember this.
Obesity.
5 markers.
Body fat percent greater than 30%. That's a lot of people.
Yeah, it's most people.
Most people.
Yeah.
Increased blood pressure. BP greater than 130 over 85.
That's a lot of people.
That's a lot of people. Increased blood sugar.
That's a lot of people.
So your fasting blood sugar greater than 110. Increased blood lipids, triglycerides greater than 150. A lot of people have that too. All of that is just improper storage. Your body doesn't know what to do with the food that you're consuming. Doesn't have muscle because you're not training, so it doesn't store it appropriately. And it just floats around in your bloodstream, causing arterial damage, deposits on your liver, deposits in your arteries. That's what happens when your body doesn't know what to do with the food that you eat because you don't have muscle because you don't train.
Yep.
Waist circumference. Measure this. In men, greater than 40 inches, and women greater than 35 inches. So you got to measure your belly. You got to put a tape around it, and you got to see how wide you are. If you're wide, you are having rapid aging.
Yeah. And that's dangerous to have that much fat around your organs. Even if it's not on your organs, it's still around your organs. That's very dangerous.
Yeah. And metabolic syndrome, which is a lot of those things above. It's high blood pressure, it's dyslipidemia, it's obesity, it's visceral fat, fatty liver disease.
She gave some practical numbers as well. And, you know, the personal trainers can definitely comment on whether they agree with this or think this is appropriate. But she recommended, and this is hard, I don't get this much protein a day. And I track, but she recommends like 110 to 140 grams of protein a day. And that's quite a bit, especially if you calorie restrict.
Consider one egg is about 6 grams of protein.
Yes. So it's easy to get plenty of protein, but that's quite a bit. The other thing that she recommended is if you're trying to reverse any kind of like metabolic disease, fatty liver, limit, carbohydrates to about 140 grams a day. That's not limiting like vegetable carbohydrates, but if you're eating any kind of like grains, rice, anything like that, limit it to 140 or less and increase the protein. I think she recommended at least every meal 30 grams of protein. And I think that's doable for most people. The 110 to 140 is hard because protein is so filling, especially if you pair it with fiber, but everybody can get 30 grams of protein per meal. That's doable.
And this is used as a medication, according to her, because it lowers triglycerides, it increases HDL, it improves the LDL size, it lowers fasting blood glucose, and decreases postprandial insulin. You get all that with increasing protein consumption. It also enhances satiety, increases the metabolic rate, protects skeletal muscle, targets fat, improves body composition.
Well, and speaking of satiety, this is probably a good leeway into the next topic that I wanted to talk about. GLPs are all the rage right now, and they are fantastic, and they've helped a lot of people. But there's a way of eating that you can do that will help you mimic the effects of a GLP, and that's high protein and high fiber. If you have ever tried to meet your protein goal and get 25 to 35 grams of fiber, you will be very full. You will not want to snack. Trust me, because I do it. I am full. I am full during my meals. I'm full during after my meals. I don't want to snack because both the fiber and the protein are extraordinarily filling. They give you a lot of satiety. And so for a lot of people, whether you can't afford a GLP or you don't want to do a GLP or whatever the case is, start eating high protein and start eating high fiber. You will experience the same effects of a GLP. You'll be extremely full.
Yep.
And that was one of the other topics that I enjoyed listening to was a lot of the lectures about fiber, because I think that's really neglected a lot, not only in like the conventional medicine, but also functional medicine. We don't talk about fiber enough and the benefits. And we should be aiming for 25 to 35 grams a day. And again, that's easier said than done because fiber is not just like eating a few strawberries and you're going to get 25 grams. You have to like work hard. I mean, you see my crazy coffee in the morning where I'm putting like my creatine, my prebiotic fiber, my whatever, my other I have 2 fiber supplements that I do in the morning. And that only gives me 15 grams. Then I have to probably eat at least a cup of beans to get the rest. But it's very filling. But all that to say, the reason I do that is because, again, fiber helps with satiety. It's going to help with insulin resistance. It's going to reduce dyslipidemia for people. But not only that, fiber is also going to feed the colonocytes in your intestines, which is going to reinforce your gut lining and i.e. help prevent leaky gut, assuming you're not also eating a bunch of other crap that's going to cause leaky gut. Also going to produce short-chain fatty acids. That's going to help with your energy. Those are anti-inflammatory. So there's a lot of reasons that everybody should be eating fiber, but they don't. And that's partly because a lot of people don't eat high-fiber foods. Like I have a fiber chart here. So the highest fiber foods are lentils, split peas, beans, artichoke hearts, chickpeas, and avocados. Also, chia seeds are up there. Most people aren't eating those because they're not the most hyper palatable foods, but you got to eat them. You should choose organic if you're going to eat them, but you got to eat them because they'll really nourish your gut.
I'll eat artichoke hearts. I like those.
They are tasty.
We got them in Rome.
I like this stuff, but I know a lot of people, you know how people are.
They're
with
fermented
food.
in Rome.
Yes. Also, as you mentioned, fermented foods are going to be really important for the gut health too, because you're going to get a ton of probiotics.
Yeah. Okay. Anything else you had on your list before I move to day 2 here?
No, that was pretty much what I had for like my main takeaways.
Yeah, this one, fermented foods and gut microbiome diversity. You decrease 19 inflammatory proteins when you increase fermented foods. The recommendation is 6 servings per week, so 4 to 6 ounces.
That's basically nearly 1 a day, which makes sense. This morning I had my 3 tablespoons of sauerkraut, a tablespoon of kimchi, and that was my probiotics this morning. I'll have another one tonight. But yeah, it's super important. And the other thing is once you start nourishing your gut better with fiber and then avoiding the gut irritants, you're going to see better Akkermansia growth, which is also protective. And you're going to see an improvement in the firmicutes and bacteroides ratio. When that's imbalanced, you have a lot of issues in the gut. And even we learned that a lot of women with PCOS will have an imbalance. They'll have more firmicutes than bacteroides. And you can change all of that with what you eat, which is cool.
Yep. Remember much about this lecture with Clearfield and Berkson?
Yes. She was really just handing it to those people that were basically kind of like what you talked about earlier, how people were very fearful of hormones and they would always refer back to like BS studies, et cetera, et cetera. She was really counteracting all those claims and she was on fire.
She is. Her video I recorded, it's up on the YouTube channel if people want to watch it.
Yeah, I highly recommend anybody that is concerned about hormones or who is refusing hormones because, I guess, if they're worried about them, they should at least listen to her and hear her out.
Yeah.
You know?
I have a slide here on the estrobolome. The estrobolome contains bacteria that can metabolize estrogen, which is a key part of the body's hormonal system. It regulates estrogen and metabolite levels. After the liver processes and conjugates estrogen metabolites with glucuronidase, it is sent to the gut for excretion through the bowel. When there's an overgrowth of bad bacteria, dysbiosis, beta-glucuronidase uncouples the conjugated metabolites and they are reabsorbed into circulation.
Well, and I think that just goes back to the idea that if you have poor gut health, you will be unhealthy. You will not get better until you fix your gut. So you can take hormones, you can exercise, which exercise, by the way, does have extraordinary benefits for your gut health. So do that. But all that to say, you can do all these things, But if you do not fix your gut, if you don't stop eating the things that irritate the gut, if you don't start replenishing your gut, you will not get better. And that's just the reality. If you keep eating junk, if you keep, drinking alcohol, doing things to cause leaky gut, you won't get better. You have to fix that before you fix anything.
And leaky gut is fairly easy to obtain these days.
Oh, yeah.
Seems to be antibiotics very easily can cause this.
Yeah.
The pesticides that we're consuming on a daily basis cause this. And the lack of fermented foods and causing lack of microbial diversity causes this. And then glyphosate in certain gluten products causes this as well.
Well, and people aren't going to like to hear this, but the people that are on carnivore diets and they're on low fiber or no fiber ketogenic diets, you're not doing yourself any favors.
That too.
You're not doing yourself any favors by starving your microbiome of food, essentially.
Right.
Right? Then you're decreasing the number of different bacteria, and that is linked to poor health. So you're not doing yourself any favors by going on these restrictive diets and not eating a diverse amount of fiber.
People use these diets to symptomatically treat themselves.
Sure.
Because they react to certain foods. It takes a long time to reestablish the gut microbiome so you can tolerate a diversity of foods. But limiting your foods because you're intolerant to them is a sign of poor metabolic health.
Correct. And I think if you are somebody that does have a severe disease and you're going on a very short-term limited diet, that makes sense to me. But the goal should be to be able to tolerate at least as many fruits and vegetables as possible, right? So obviously that doesn't mean you should be able to tolerate pizza and donuts. That's not what I'm saying. You shouldn't eat those, but you shouldn't only be able to eat chicken and rice and nothing else. You should be able to tolerate a wide variety of fruits and vegetables. That's a sign of good health, and it's good for your gut microbiome.
Yep. Clinical conditions linked to estrogen dysregulation via dysbiosis. We know some of these.
Gosh, it's like everything.
It's like all these, we see that every day. Endometriosis, uterine fibroids, PMDD, PMS, breast and gynecological cancer risks, menopause and metabolic effects. Let's see. Estrogen microbiome interplay influences adiposity and insulin sensitivity, impacting cardiometabolic risk. When you have menopause and GSM, so that's symptoms related to menopause, recurrent UTIs, that's low estrogens.
Yep.
And then you have urogenital microbiome changes, decreased lactobacillus, and increased pH. UTIs are so common. You see them every day working in the urgent care. And I thought, it was so weird. Why do women get so many UTIs? I thought this when I was a young PA working in urgent cares.
It's still crazy to me. The more I know now, I understand, but I always was perplexed too because I've never had a UTI. So I'm like, why do some people get these all the time?
Right.
Like, it's crazy.
And mainstream medicine doesn't have an answer for this. Like, you're wiping wrong.
Yeah. Or they just send them to a urogynecologist. They go through an very invasive workup. And then they're basically told, you have recurrent UTIs, take an antibiotic every time.
Macrobid for the rest of your life.
Yeah. And, the craziest thing is a lot of young women also come into urgent cares with dysuria. They don't actually have UTIs. Their culture will come back negative. But guess what they do have? That can be endometriosis, right? So if you have painful urination and it's intermittent and you're premenopausal and it's not actually a urinary tract infection, right? Because you know by the culture, you should start thinking of endometriosis. And then that should get your brain thinking about other things too. But yes, in older women, they get that decline of estriol and estradiol. In particular, they start getting urinary tract infections because estradiol acts like a natural antibiotic in the bladder and in the vaginal canal.
Brilliant.
So, I mean, it's obvious to us, but I guess to a lot of other people, it's not.
It's going to take a lot of learning.
Yeah.
Let's see what else we have here. Proposed mechanisms for microbiome and endometriosis. There's immune dysregulation, microbial byproducts like lipopolysaccharides activate an immune cascade, leading to a polarization in the immune system, the Th17 Treg imbalance, and cytokines, IL-6 and TNF-alpha, that prime pelvic inflammation. And there's a poor estrogen metabolism. There's altered beta-glucuronidase activity. It changes circulating estrogen recirculation and supports ectopic endometrial cell survival and proliferation.
Well, and that makes sense that we think there's an immune component or a dysregulation, because now we're starting to think that endometriosis is actually an autoimmune issue for a lot of people.
Yeah.
I actually remember a friend who I did the world race with, and she had severe malaria when we were in Ethiopia. And then years later, when we got back to the US, she got diagnosed with endometriosis. And I always wonder if there was a connection there that happened with that exposure. And like, it was very severe. I mean, she was hospitalized for it. And so I often wonder, in a lot of women that have endometriosis, what kind of maybe stealth infections they may have, or what kind of immune dysregulation or leaky gut could be driving that. But endometriosis is terrible too, because what it does is it's going to form all this ectopic tissue in and around the fallopian tubes. It can be all over the intestines. It can be as high as the diaphragm, even in the heart. They've had a documented case where one time somebody had endometrial tissue in the heart.
Yep.
And it's hard to diagnose outside of laparoscopy. Like a surgical laparoscopy is the only way you can definitively diagnose it. And so it's a pretty devastating disease for people, and they live in severe pain. So to be able to treat or try to prevent or help those symptoms would be huge.
Yep. Comes down to a functional medicine approach. Barrier dysfunction, increased intestinal permeability, leaky gut, permits antigen LPS translocation, and systemic peritoneal immune activation and pain sensitization. That LPS, we can test for that here at Iron DPC. We use Vibrant all the time to test for it. It's like a $200 test. It looks for gut barrier dysfunction. And it's so common, actually. And it leads also to nutrient deficiencies, because people have all this inflammation in their gut and they don't absorb their nutrients anymore. So it leads them to chronic fatigue, low hormones, low thyroid function. It's like a whole downstream effect of just the breakdown of the gut.
Yeah. And then they're going to get disease after disease or syndrome after syndrome, because it all starts with the gut. You have to fix the gut or you're not going to get anywhere.
Metabolic shifts reduce short-chain fatty acids, butyrate, impair Tregs and barrier integrity. Altered bile acids modulate inflammatory signaling relevant to lesion microenvironment. So how do you improve your short-chain fatty acids?
You have to eat more fiber.
Yeah.
So you have to eat, and again, preferably if you can, always get organic, right? Because we don't want organophosphates and we don't want other pesticides. But eat more lentils, eat more beans, eat artichokes, eat cruciferous vegetables. You can also take a supplement called butyrate.
Yes.
And Brian Johnson actually takes that as well.
I prescribed it to patients.
Yeah, you can actually take butyrate, but that's one thing that you can do is just feed your microbiome. They will create short-chain fatty acids. Exercise also increases short-chain fatty acids. So exercise, eat high-fiber foods, eat probiotic fermented foods, and you're already one step ahead.
Yep. Reproductive tract dysbiosis, lower lactobacillus with increased potential pathobionts like Gardnerella and Streptococcus associates with endometriosis and may influence local immunity. Gut peritoneal crosstalk, hypothesized microbial immune signaling between gut and peritoneal cavity may amplify inflammation alongside retrograde menstruation.
Well, yeah, that's one of the other thoughts behind endometriosis is it's retrograde blood flow, menstruation, and that somehow contributes to the ectopic endometrial tissue that forms. So yeah, I could see that. It's all these microbes literally talk to us.
Yes.
Not literally talk to us, but they talk to our organs and our systems, and they play a huge part in our homeostasis.
This is an interesting slide on progesterone metabolism. And pregnenolone is a GABA receptor modulator that supports calm mood and sleep. So one of these patients may have improvement in sleep with progesterone, the other may not.
So it's funny with progesterone. I always find it so interesting that it helps people sleep. And the reason for that is I actually sleep best during my follicular phase, which is when my progesterone is basically,
Not detectable.
not detectable. I sleep well the whole cycle, but I'm obviously much cooler during my follicular phase when my estradiol is nice and robust. My heart rate is a little bit lower because I'm not having that sinus. I guess your heart rate increases with progesterone. So I'm having a little bit of a lower heart rate. So I always find that interesting, but it kind of makes sense because if women take oral progesterone, they're going to get a huge amount of allopregnanolone, and that is very kind of suppressing.
Sedating.
It's sedating even. So you are basically just sedating yourself. So I guess that could make sense why they're sleeping, because if they weren't sleeping before, well, now they're sedated and they are sleeping, or at least they feel like they are, but are they really getting good sleep, or are they just being sedated? I don't know.
But what you're saying is the estrogen is better for sleep.
But yeah, estrogen's really important for sleep. For one, again, because it's going to cool you off. Estradiol actually decreases your body temperature a lot. So if you look at somebody's body temperatures throughout their cycle, they'll be significantly lower from like days 1 to 12, 13, 14. And then once you're in your luteal phase where you're progesterone dominant, those body temperatures increase quite significantly. The heart rate increases, the appetite increases. Your HRV is terrible during your luteal phase because your heart rate increases. And so I always found it interesting because I'm like, my biomarkers, my sleep, everything's better when my estradiol is higher. Mm-hmm. But, everybody's different. And if the progesterone helps them sleep, then it helps them sleep. But ultimately, it's just kind of sedation more than anything.
Progesterone is sometimes the gateway drug to bioidentical hormone replacement therapy.
Yeah.
Because they tolerate it very well. It's easy to take. It makes them sleep and they feel better. Mm-hmm. So,
in my opinion, I do think that it is women, they can optimize in other ways to where they don't need to sedate themselves with oral progesterone. And what I mean by that is not that they don't need it, but if they're optimizing for everything else, their circadian rhythm health is on par, their cortisol health is on par, they're getting enough estradiol, they should be able to just do intravaginal progesterone suppositories, and they should still sleep fine. If you have enough estradiol, your cortisol is not through the roof at nighttime because your circadian rhythm health is optimized. You're not eating late. You're not staying up late. You're getting morning light. And then you're using progesterone more appropriately. Women should still be able to sleep. They shouldn't, in my opinion, if you can't sleep without a sedative, which is what oral progesterone kind of ends up being, there are benefits to it, and I'm not saying there's not, but if you can't sleep without a sedative, then something's not right. Mm-hmm. You need to fix something elsewhere, because you slept without a sedative for the first 50 years of your life, most of us. So that only leads me to believe that there's something else in that hormone symphony or hormone cycle that's off.
Yep. PCOS labs. What's the order? Elevated.
Oh gosh, a lot.
Elevated free testosterone, androstenedione, and DHES. Elevated estradiol, TSH, and prolactin. Low SHGB, low progesterone, an LH to FSH ratio greater than 2. It's found in more than 83% of the PCOS cases. Mm-hmm. And of course, elevated fasting insulin, glucose, and A1C. That's interesting about the high estradiol. We've seen that in PCOS.
But the interesting thing is with PCOS, it is not a syndrome of elevated estradiol. Sure, maybe in comparison to the progesterone, the estradiol is elevated, but PCOS actually is an issue with typically low estradiol. And the reason is because PCOS women cannot convert testosterone to estradiol well. Those receptors or those aromatase enzymes, they don't work well in women with PCOS. And so if you actually look at PCOS women's estradiol levels on a plane, say a monthly plane, they're actually on the low end of normal for the most part. And they have a relative androgen dominance more than anything. And then the problem is compounded because they'll have elevated LH. And what does LH do, unfortunately, is it's telling the ovaries to make more testosterone. Now, in a normal woman that doesn't have PCOS, they should be able to convert the testosterone to estradiol, but PCOS patients don't. So then they get symptoms of high androgens. They get hair thinning on the top of their head. They'll get hair thinning. They get chin hairs. They get hairs in other places that they shouldn't have. They'll have actually a lot of other issues, but those are just the main ones of hyperandrogenism that they'll have. They might have excess cysts on their ovaries. They might have menstrual irregularities, but really it's not an estrogen dominant issue. It's actually the opposite. They don't have good enough estradiol, and they're actually more androgen dominant. And it sucks because that's a lot of women. We see so many labs with an LH to FS ratio that's 2 or 3 times greater than what it should be. Mm-hmm. And part of that problem is because all PCOS women are insulin resistant, even lean ones. It doesn't matter if you're lean, you're still insulin resistant, most of them. And so those particular patients have to be really careful about what they eat, because the more you're stimulating insulin, the worse your hyperandrogenism symptoms will be. And so it's tough because, as Dr. Gersh says, back when, our ancestors roamed, PCOS existed, she says. But back then, before we had all of these, fake lightings, back before we had a bunch of junk food and BPA, she says that it was actually an advantage to have PCOS because those women were actually a little bit healthier and it controlled their fertility a little bit more. So it was actually a little bit of an advantage way back when, before all of the regular world came to be. But now we have constant food. We don't have any kind of famine. We have tons of fake lights that affect our circadian rhythm. And so now PCOS women are very sick.
Yep. There's a microbiome signature to PCOS with reduced microbial diversity. Mm-hmm. Women with PCOS consistently show lower gut microbiome diversity than healthy controls.
Correct. And they will have excess firmicutes phyla in compared to the bacteroides. They'll also usually have lower akkermansia. And interestingly, if you did a fecal transplant, like just theorize on a PCOS patient, and you put a healthy microbiome or a non-PCOS microbiome into that PCOS patient, you'll actually cure their PCOS.
Right.
Which is insane.
And vice versa, you can take a PCOS microbiome from a mouse and put it into a healthy mouse, and
give them PCOS.
That mouse will get PCOS phenotype. Yeah,
because that dysbiosis also contributes to the hyperandrogenism as well. So the unfortunate reality is if you do have PCOS or you have any kind of symptoms of it, which is like a lot of women have a quote unquote touch of PCOS, even if they don't meet all the criteria. And
a little.
Yes. And the criteria are symptoms of hyperandrogenism or elevated testosterone. That's one. You have to meet that criteria plus either polycystic ovaries or greater than 12 follicles on each ovary, or menstrual irregularities. So you have to have the hyperandrogenism and you have to have either polycystic ovaries or menstrual irregularities. I know tons of people with hyperandrogenism, and I know tons of people with menstrual irregularities, tons with an abnormal LH to FSH ratio. I mean, this is so common. So it's unfortunately a lot of women.
Yep. Let's see. Functional impact: reduced short-chain fatty acid produces lower butyrate, gut barrier dysfunction, endotoxemia, and chronic inflammation in the PCOS. A study in a letrozole-induced PCOS rat model, acetate and short-chain fatty acid supplementation reversed disrupted ovarian morphology restored estrus cyclically, and increased 17 beta estradiol levels.
That's pretty cool. So it sounds like in women with PCOS that were trying to conceive and they did letrozole, which for anyone who doesn't know what that is, it's basically a drug that actually blocks estradiol, which then tells the brain, the hypothalamus and the pituitary, to then hypersecrete FSH way above the normal levels. And what that does is that's going to induce follicle maturation way more than it would otherwise, because in PCOS, a lot of them don't even ovulate. And so that's what that does. And it sounds like pairing that with the short-chain fatty acids gave them better outcomes, which again makes sense because everything's tied to the gut.
Yep. Let's see. Gut permeability, ovarian inflammation. PCOS exhibits a significant higher serum zonulin levels, a marker of intestinal permeability. And then increased intestinal permeability, the leaky gut allows lipopolysaccharide and bacterial fragments to enter circulation, activates TLR4 signaling in ovarian theca cells, and that increases androgen synthesis.
Yep, those darn theca cells. You can't, it's so hard because PCOS patients, and it's not just PCOS patients, it's a lot of people with chronic disease, you can't eat the way that some other people eat. You just can't. Most PCOS patients should not have dairy. They should have no dairy. But it's just the reality. If they want to optimize their health, if they want to keep the PCOS under control, they should not have dairy. You can't eat the same way that everybody else that you see eats. You have to really dial in the nutrition. You have to get a lot of phytochemicals, polyphenols. You have to get plenty of protein. Monounsaturated fat is huge. But you just can't eat the way everybody else eats because you have leaky gut if you have PCOS.
Right.
You have really any chronic disease, you have leaky gut, but we're talking about PCOS. They can't just eat whatever they want.
Take a look at this. Another reason I don't like to prescribe antibiotics when it's not absolutely indicated is animal models confirm that antibiotic-induced dysbiosis or high-fat diet dysbiosis increases ovarian inflammation and ovulation.
Yeah.
That's crazy.
That's why antibiotics are bad, and you only want to take them if they're indicated. But that's also another reason why, again, just ringing it home, PCOS patients have to have the diet dialed in. And they have to, it's okay to have fat, especially if it's good fat, like monounsaturated olives, olive oil, walnuts. Those are really good monounsaturated fats. But you have to be so good about the diet, and you have to really feed that microbiome.
So basically this is saying that carnivore diet is as bad as antibiotics.
I don't think the carnivore diet's good. I don't. I don't see any data that long-term carnivore diets are good for people. And we were talking about this not long ago. Bless his heart, Dr. Kiltz was a staunch, ketovore, carnivore, whatever you want to call it. He was meat, eggs, and butter type deal. He stopped doing that. He started eating more fish, and he started incorporating vegetables because he had a lot of plaque buildup when he got a coronary artery calcium score done. That was one of the things that made him stop and think, this is probably not a good idea, right? And so, that's just one thing, but I don't think you're doing yourself any favors by only eating meat, butter, and eggs. Also, that's extraordinarily restrictive. And that can't be good on your quality of life.
Good for him for following the data.
Yeah. Oh, I respect that so much.
You follow the ApoB, and if it's getting out of control on your diet, you got to make some changes.
Well, look at how much we've changed a lot of our perspectives over the years.
Yeah.
Years ago, I thought carnivore diet was cool. Yeah. And now I'm it's stupid.
Yeah.
It's because I'm not married to any ideology. I just want to know.
We follow the data.
Yeah.
You look at the labs on patients who have been doing carnivore diet, and they're horrendous.
Yeah, they're not good. For the most part, there's a select few people who have the genetics maybe that they could handle.
Sure, it might be fine for them.
Yeah, it might be fine for them. I can think of one patient in particular I know who's a friend of yours that eats a lot of ground beef and butter and eats some other junk too, but he never has a bad lipid panel.
Perfect lipids.
But everyone else I know that does a carnivore diet, they have an outrageous lipid panel.
Right.
And that's not good. Especially if the ApoB is really high. That's really not good.
Very problematic. Follow
But,
the ApoB,
yeah.
treat it.
All you need to do is follow the data. You don't need to be emotionally invested in an ideology.
No.
You don't need, it's just being unbiased. Follow what the data says. Yes, how you feel is important, but if you feel good and your labs are terrible, something needs to change, right?
Right. That's what we're all about, following the data. I'm okay if you want to try out a diet, but if it makes your labs worse,
I'm going to tell you.
I'm going to tell you.
Yeah.
It's terrible.
And because that's what you're there for. You're there to give them the best advice possible and to obviously prolong their life and their health span.
Yep. Let's see. Why the mouth matters. That was a great lecture.
Oh gosh, that was really.
Yeah.
We were both like
Blown
eyes
away.
wide open. I know oral health is important, but I think we overlooked that way more than I ever thought. It's just never the first thing I think of is like oral health. I know the connection between hypertension and oral health, but hearing that dentist talk about how many asymptomatic severe infections that she finds in people who suffer from like a neurocognitive issue that resolved after she treated the infection or whatever the case may be, I was so shook because I'm like, how many people are walking around with terrible infections and they don't even know because either they don't have any symptoms of it or it's just mild and it's not enough to really make them advocate for themselves.
Well, in our medical training, we didn't really get much training on dental health.
No, it was
And I
so
don't
brief.
think MDs do either or NPs. I think it's across the board.
Just
separate.
refer, yeah.
It's just the dentistry is completely separate from the medicine.
Mm-hmm.
But as we know in functional medicine, that's not true. Everything's connected. Yeah. And sure enough, when you have a stealth infection in the mouth, it can cause symptoms all the way down somewhere else.
Yeah. Well, it can cause heart disease. We know that.
We know that. We learned that, right?
Yeah.
No.
But it was like, that was like the only thing we really learned.
It's like, endocarditis from
Yeah.
a mouth infection.
Yeah.
No, I had a patient, and this one really put it in perspective for me. He came into me with essential hypertension. So he put his hands out, and it was like this, shaking and trembling.
Mm-hmm.
Did a full history on him, and he's like, yeah, I got this little pain in my jaw here. I'm like, okay, can you get that checked out? So we went to a dentist, and the dentist did x-rays, and the dentist was smart enough to know that the x-rays weren't good enough. Mm-hmm. Sent him to an endodontist. The endodontist did a cone beam CT of the mouth, found the infection, cleared out the infection. He came back to me. The essential tremor was gone. Perfectly still hands. And essential tremor is typically goes to a neurologist. Neurologist might work it up. They don't look at the mouth in that workup. And they'll probably say, well, it's essential means we don't know what it is. Here's a beta blocker. Mm-hmm. Right? So that's the treatment for it.
And that's how the specialists are trained now is kind of like you treat what I know. And
Right.
that's how, so that doesn't even surprise me, but it's crazy. Like what if he didn't get that evaluated?
He would have had
It may have
a tremor,
progressed,
and it would have
yeah, or-
progressed
yeah.
to probably something worse down the road.
Yeah. So the oral health is huge. And that's why immediately when we get back, I was like, I need to make sure I have a couple questions in our new patient questionnaire about dental health.
Right.
So that we know, if you're having recurrent cavities or if you're not seeing a dentist, like you need to get this in check because it's going to cause issues for you down the line.
And there's a really good picture. I'll put it up here on the screen of a standard dental x-ray and then a cone beam CT scan. And you can see just even by a layman, you can see the difference.
It's bad. It's a terrible infection.
Terrible infection of the mouth.
Well, and think how many people that get quote unquote chronic sinus infections, and it's really like a fistula or a pocket between the sinus floor and the
mouth.
and the teeth.
Yep.
They
get recurrent sinus infections.
Yeah.
And that's another common one. You go to the urgent care. People,
Yeah.
sinus infections, they come in recurrently. It's probably like the top 3 things people come into urgent cares for.
So common.
Recurrent sinusitis.
Yeah.
And this is another thing that drove me bonkers when I worked in urgent care. Like, why do people getting sinus infections? I've never had a sinus infection.
Yeah.
Why do these people keep coming in with recurrent sinus infection? It seems to get better temporarily with doxycycline. What's going on here?
Well, and it makes sense because it does temporarily get better when you treat it, but you didn't treat the root infection, which is, I mean, in the teeth more or less, but
In the teeth is one reason.
Yeah, it's creeping up into the sinuses because of the proximity to it.
The other reason I've identified is mycotoxins, so chronic fungal infections in the sinuses. And these people who have mycotoxin problems, they'll get fungal biofilms in the sinuses. And I've started actually to prescribe intranasal amphotericin B. And it's been working for some of these people with chronic sinusitis issues.
That's interesting.
I learned that from Dr. Donald Dennis. He's an ENT in Atlanta. He's on some of the Zoom calls every week. And he's given this lecture twice. It's how he'll do endoscopic procedures. He'll go and he'll clear out these he calls them fungal balls, clears them out, scrapes them out, sprays it with amphotericin B. And these people get remarkable improvements in a variety of symptoms.
Amazing. But I wonder how many of them there's a dental component.
Yeah.
I mean, it's probably so many people.
A lot. Let's see. That's pretty much it.
Yeah, I can't think of any other hot topic. Those are mostly all the things that I remember that excited me.
Well, very exciting here. We covered a lot of topics.
We sure did. Yes, there was. It was so big. Such a big conference. It was a lot of fun.
Hang out with some friends. We got to see all the friends that we see on the Zoom calls. Those events are nice to meet up with them. And we're on these academic Zoom calls, Monday through Thursday every week. And it's cool to come to an event and actually meet them in person, hang out, and go to dinners with them. That's fun. All right. Well, we'll see you at the A4M West Palm Beach. We'll be there.
We sure will. The whole team.
The whole Iron DPC team will be there in West Palm Beach. That's in April. And we'll have new information from that one as well. Thanks for joining.